Well, hello and welcome. Thanks to you who joined us tonight. I'm Erica Carlisle from the APSA Ethics Committee, and I'm excited to welcome everyone to our second Connect and Share APSA-sode that's put on as a collaborative effort from both the Ethics Committee as well as the Wellness Committee. So our goal for tonight is to explore some of the challenges that we all face when we experience an intraoperative complication. So specifically focusing on how do we recognize when we need help? How do we ask for help? And how can we recognize and support our colleagues when we think they may need help as well? So our session will be facilitated by Mindy Statter, and Ronnie Sellens and Christy Ryland will help moderate. So thank you to everyone for joining us, and I'll turn things over to Ronnie for some brief guidelines for what I know will be a great discussion.
Hi, everybody. Good evening. So I'm just going to go over a few rules and logistics just about the sessions for those of you who haven't been here before. There are two ways to participate. The first thing is just raising your hand during Zoom, and then Mindy, who's running the session, is going to acknowledge that. If you want to, you could also put questions or comments in the chat, and Christy Rialan and I are going to be monitoring that. And feel free to enter comments in the chat anytime, whatever you'd like. The other thing, it's really important to avoid any HIPAA violations of protected patient information, hospital information, and then also to really be respectful of other people, not to interrupt, and to also reflect if you are speaking or if you're writing, to reflect on the experience. It isn't about sort of fixing everything. It's really more about sharing the emotion and the experience behind all of this. And we'd really love, if you can, to keep your videos on and stay present. And I'm going to turn it over to Mindy. Is it Mindy?
Almost. Before we get there, we've created a brief video that really highlights what moral distress is. So we'll share that with you. For those that joined us at the prior episode, you may remember it, but I think it's a really great contribution and sets the stage for our discussion.
What is moral distress? Moral distress is the result of the perceived violation of one's core values with the feelings of being limited from taking an ethically appropriate action. It often occurs when you know the ethically appropriate action to take, but are prevented to do so due to external restraints. For example, the ethical tension experienced when advocating in the best interests of a baby, but faced with the request for non-beneficial treatment. Moral distress is characterized by feelings of frustration, anger, anxiety, guilt, compromised integrity, powerlessness, and psychologic disequilibrium. So why should we address moral distress? Moral distress must be recognized and acknowledged so that we can understand where these feelings originate. Moral distress can be mitigated when we have an opportunity to openly discuss our experiences and feelings. Third, moral distress has the potential to negatively impact work performance, retention, recruitment, job satisfaction, and the quality of patient care. Lastly, moral distress, when unaddressed, can result in moral residue and injury and can generate worse psychological outcomes such as depression and burnout. We are addressing moral distress because there is a need. Barriers to educate and intervention about moral injury are unfortunately ingrained in our surgical culture. There is the stigma and shame associated with moral distress and the surgical hierarchy. In this hierarchy, senior surgeons may be seen as impervious to moral injury, inhibiting other faculty members or trainees from sharing their feelings or emotional reactions or seeking help. By creating a safe zone, we generate a moral community, a group united by a shared common goal with moral implications, the well-being of our patients. The relationships within this moral community allow for vulnerability, for questioning, and tolerance, for expressing uncertainty. Moral distress can be mitigated by convening as a group and creating a safe zone to share and validate feelings. These gatherings provide the opportunity to equip participants with the vocabulary to deconstruct the case, identify the ethical principles and core values that were challenged or violated, to share coping strategies, and identify practical takeaways to diffuse conflicts in the future. I'd like to take a moment to provide a framework for the Connect and Share gatherings. The facilitator should outline the framework for the session. 1. Begin the session and set expectations. No HIPAA violations. Introduce the moderator, the person moderating the chat. Raise hands for discussion or participate through the chat, please. 2. Brief case presentation. Don't get mired down in the clinical details. 3. Reflect on the experience. 4. Share emotions. And 5. Takeaways, practical tips, communication tools, and templates to frame and conduct patient discussions. Connect and Share gatherings provide the tools for moral resilience, which can be fostered with compassion, self-compassion, and an environment that allows for raising ethical concerns. Negative feelings can be rechanneled into opportunities for learning and growth. We'd like to take this opportunity to invite you to gather and share. Join us as we conduct our own Connect and Share session. Thank you.
Okay, thanks. So to start our conversation, I'm excited to introduce Dr. Sharif Ilal, who joins us from Montreal Children's Hospital at McGill University, who will bravely share a story from his practice with us.
Thank you so much. Thanks for the invitation, and thanks for the organizers for including me. Yeah, I'll just take a few minutes to share a story. It's been actually 5 years. It's around exactly the 5-year anniversary of those events. And I was just thinking about the session tonight, and it's really amazing how clear the details are still in my mind, as if they could have happened yesterday. So let me just give a little context. In August of 2016, my father, who was living alone in Los Angeles after my mom's passing away, was diagnosed with a myeloproliferative disorder and quickly deteriorated. And, you know, I was trying to do my best from here in Montreal across the continent. And then in January, he was actually admitted with a platelet count of 3, very critical, to City of Hope in Southern California. I was actually in one of my missions with the Mercy ships at the time in Benin, and I had to leave my mission early and rush back to LA. And from January until September, it's a bit of a blur. It was a very, very difficult time in my life. I was having to go back to Los Angeles at least a week a month, put some of my practice on hold, but I still, you know, had a lot of obligations as the division chief here in Montreal and with everything else. And then my dad in early September was admitted urgently with a sudden deterioration after he had been stable for a while. We rushed to see him, and he passed away within a few days. And we had his funeral on September 11th. It was a Monday, 2017. I flew back to Montreal on Wednesday, and I was supposed to present grand rounds on Thursday, and they had emailed me saying, I'm sure you're going to cancel it. And I said, no, I'm not. I'm actually going to come and give it. So I came back to Montreal on Wednesday. I presented grand rounds on Thursday. I left for the AAP meeting in Chicago on Friday. I came back on Sunday, and I started my call week on Monday. And at the time, I really thought all this was good. You know, I'm just going to carry on with my life. It's been a very hectic time, and now maybe there's some normalcy. And I started my call week, and on that Thursday, I had an elective day. And I was doing just, you know, smaller cases, and was also on call. So it was just that, you know, you all know what a hectic day looks like. Just things were moving a bit slowly. There were some delays, and, you know, I was trying to be 3 places at once. And my last case was a thoroglossal duct cyst. And, you know, it's not a case I think much about. You know, I mean, we've all done these more times than we know. I've done them in very difficult situations in Africa with multiple recurrences and so on. So it's a case I consider just a thyroglossalal duct cyst. You know, we all know what this just syndrome is, right? Like just a appy, just a hernia, just a line. Of course, there is no just, but that's really how I was thinking. And it's amazing that the family in the pre-op holding had seen how I was sort of just a bit agitated and running around from one place to the other. And they actually said, you know, we're okay if you would like to cancel our son's surgery. He was a 3-year-old boy, and we can reschedule. And I said, no problem. I'll get it done. And I was taking my junior fellow at the time, so he was just a couple of months into his training. He had never seen a thyroglossalal duct cyst. You know, I thought the case was going fine. Nothing really unusual. Divided the bone, getting ready to remove it, and suddenly realized that I did not divide the hyoid bone. I divided the thyroid cartilage. And it's really a blessing that I realized it at the time, because I was about to remove it. And you may think this is so bizarre, it could never happen. There are actually a lot of reports in the literature about these disasters happening in thyroglossalal duct surgeries. And of course, most of these patients, if you end up removing the thyroid, they have a trach for the rest of their life. In any case, I called the ENT surgeon. ENT surgeon said, just, you know, if you didn't remove anything, just put a few sutures. I did, but I had no idea what to expect. You know, thankfully, this child did well. Of course, had multiple rigid bronchoscopies and laryngoscopies and multiple visits, and, you know, was in the hospital for a long time, but thankfully he recovered completely. But it was really, you know, it really shook me to the core. And I was on call that week, and right afterwards, I just continued on. I had an appendectomy to follow, planned, and just continued on with my call, continued on through the rest of the week. The following week, I actually started having pneumonia symptoms, but I, again, complete denial until my wife insisted I go to the hospital, had to be admitted for a couple of days, and then came out, and she insisted that we just stop. Like we just take a break. And I actually canceled everything, and we went to Florida for a few days. And that was actually the point I started, you know, reflecting and trying to get some insight into it. And I realized that I had actually been in a fog for a good part of the year, if not the entire year since January. And, you know, nothing was really clear. And, you know, it dawned on me that when you are in a fog, you can still drive, you can still walk, but it's just a disaster waiting to happen. And I realized that actually none of my partners talked to me about, you know, this situation I was in. I mean, they were very supportive, really have an amazing group. I feel blessed to be working with the people I work with, but it was never brought up. Months after month, it just wasn't, you know, it just wasn't an issue. And I remember after this complication, I actually reached out to the anesthesiologist who was in the room with me, who was a really good friend the next day. And actually, you know, I had, you know, just saw the little presentation and the feelings of guilt that come. And, you know, in the following few days, my guilt was so intense that I told my wife, I wake up in the morning and I just feel sick. I really feel like I have a physical problem, you know, there's like a knot in my stomach. And of course, I felt guilty towards the patient and the family, but also towards so many other people, towards my fellow who had such a traumatic experience early in his training. Towards my division, I felt like as a division chief, I set such a bad example for not knowing when to stop and to check out and just to interrupt and really take your patient's advice into account. For my department, I thought, gosh, I'm gonna go and present this, and there's no way I can say that I was just recovering from my dad's passing, or that's gonna look like I'm giving excuses. And it really, that incident, and until I took a few days off, has really changed the way I see things in a very fundamental way, starting with myself. Just how I view others, in the ease I now have, I think, of reaching out to others that may be in distress, instead of just sitting back and being a spectator to the incidents and kind of waiting for somebody to come or not come more often. And also how we can, really be so close to each other physically and collaboratively in our work, but yet not really pick up on these dilemmas that we have to go through. So anyway, maybe I'll just stop here because I think there's probably a lot of comments and questions, but I think I'll just stop here and yield back to the moderator. Thanks so much for allowing me to share this story.
Oh, thanks, Sharif. I think I'll transition the discussion over to Patrick.
We're going to do a quick poll, and then before we start our discussion. And so I would ask that either you turn on your camera because we need to see hands. This is going to be a real life poll, not a Zoom poll. So we want to see faces and hands. And if you're not going to show your face, you could raise your hand as an emoji. But I'm going to ask three questions. And my first question for the group, based on Sharif's story, thank you, Sharif. How have you ever been in a situation in which you experienced a serious complication in the OR or in the hospital and you needed help to get through the day? So if you've been in that situation, raise your hand. And I would ask that you put on gallery view. It'll make a lot more sense, I think, if you're on gallery view, but there's a lot of hands raised. So I appreciate that. And if you've been in this situation, put your hands down for a sec, but if you've been in this situation, did you ask for help? So there's a few hands. Thank you. And the last question is, if you're in this situation, was help offered to you by your colleagues and partners? So a couple of hands, a couple of this too. So I think this is a situation that affects a lot of us, that has affected a lot of us, and will continue to do so, and something worth talking about. So with that, I'm going to turn this over to Mindy Statter, who's going to be the leader of our discussion tonight.
Thank you. First, I want to thank you, Sharif, for sharing this case, and thank you for your courage, because your vulnerability provides an opportunity for all of us to identify with you. You shared several of your feelings, and I think one of the important components of this framework is to share the feelings and validate the feelings, and this is a way of almost normalizing and validating what we're going through in terms of moral distress. You highlighted what you thought some of the root causes. This is not a root cause analysis, but you highlighted the protracted illness of your father, your sense of loss, grief, jet lag. You described this visceral response that you had later. Can you share again, just list some of the feelings that you were feeling both that day as well as later?
Yeah, thanks, Mindy. The one thing that really, really bothered me, and maybe in some ways still bothers me today, is that I still couldn't really explain it. I just could not explain how I actually made that mistake. There was nothing unusual. This is not a patient who had an infection before or a ruptured cyst, or it was a very routine case that I had done at least 100 times, if not more. And I really felt that I was, and my fellow very much put it that way, like I was just in a tunnel vision, and it was nothing that I probably could have done differently that night, except just not to do it, just to take the parents' advice and realize, if they're telling me they're seeing me unfit, I should be honest enough with myself to realize that I am unfit this night. And I think that's kind of a little bit again of what was alluded to. It takes a lot of humility and a lot of courage that I have to say I just didn't have at the time. I really felt I could do it. I've been through difficult times before, and things are over, and so it was really just sort of a feeling of failure that you could not explain, that you could not rationalize, like, okay, this is why I failed, because it felt like it was just poor judgment. And it was the poor judgment, not so much a surgical judgment. I mean, obviously there was a judgment error, but really a poor judgment in terms of how one conducts their life. And I have to say, like, I hope that I've learned enough from that so that when I do go through times like this now, I have more insight into realizing how to sort of heal before getting into another event. But that was really what bothered me the most, is that I did not have the insight to actually prevent an event like that from happening at the time.
Before I get to Terry's comment, I want to just circle back to something that a term you used multiple times, and that was your sense of guilt. And I think for a lot of us, there's a conflation between guilt and shame. And guilt is, yeah, we did something bad, but it's reparable and you can change your behavior. But the difference is with shame, you judge yourself as being bad, and I did something bad, and you're inadequate. And we all have that critical inner voice. And it's this sense of shame that contributes and perpetuates the feelings of isolation and actually dealing with that critical inner voice. And I think it took a lot of courage on your part to identify that, yes, this was guilt, and how you can fix it in the future and delineate those factors. I think the whole purpose of these connect and shares is that the clinical case is important in terms of being a springboard for identifying the feelings, but more importantly, let's look at the factors that contributed to that situation and get under the surface and address these systemic issues that potentially created that situation. Terry?
Again, thank you, Sharif. I mean, listening to you share the story is, I mean, my heart breaks and my eyes tear up. And I also realize that most people on the screen have had something along the same line happen or will have it happen to you. It's going to happen. And I was reflecting that we often look at the OR as our escape place, our inner sanctum. You know, we don't have to answer our pages. That's where we go to turn everything off. Whether or not you're suffering with a family illness, a child illness, a divorce, whatever external factor, we are trained to think that that's our inner sanctum, but maybe we need to challenge that narrative and almost give ourselves permission to think about an internal safety stop about our wellness, to go to work and walk into that inner sanctum, because our focus cannot be 100%. And that narrative and that we have told ourselves as surgeons for decades and decades maybe should be challenged.
Gary, I'll just say that is such an important point. I mean, I used to think, if you're really tired, I'd rather be in the OR than doing a clinic and speaking to people, because, like you said, you just focus on one thing, it's all technical. I travel halfway across the world, different time zone. I walk into an OR that I have not even walked into before, and I feel like, hey, I'm home, this is fine. And you're right, that is not always the case. Absolutely. I mean, there are times when it's not the right place to be. And I think we just need to recognize that.
Anyone else want to share a similar experience, or how they reacted, or some coping strategies that they've used in a similar situation? Kurt, thanks for putting this in the chat. Why don't you share it with the group, please?
So in the 1990s, when we were learning how to be laparoscopists, I was operating on a general surgery with a general surgery resident at the nascent beginnings of when we had a fellowship, and I had a gas embolus in a newborn with a death. It took a couple of hours to resolved that. And I had 2 more cases on the list. And so I did an API and a central line after that. And in retrospect, I'm embarrassed that I didn't have more presence of mind at the time. And yet I also recognize it really wasn't the culture of our institution to ask for, call and ask for help. One thing, if you find a problem that you don't understand, to call your older partners and ask that question. But it wasn't, it never dawned on me to call my partners at that time. And in retrospect, I look back and I just think what a moron I was. I couldn't believe that I let that happen. Not the event with the child, but rather that I kept operating. I should have been wise enough to stop. Or in our hospital, when there's a death in the cardiac room, they stop the cases. And I've thought for years that why we aren't wiser about that in general surgery. So I'm going to stop there so I don't talk too much.
Tamara?
Yeah, I was just gonna comment. I had recently had a case that didn't go well, and I think just the thought of presenting it at M&M, I felt like I was kind of recovering, and then just the thought of presenting it there just really brought up a lot of all those feelings again. And I remember telling a friend of mine, this was during residency, a non-medical person was asking, like, well, what is M&M? Like, what do you guys do? And I said, well, it's like going to confession, only there's no forgiveness at the end. And I think that's really kind of not right. I think we need to change how we do some of these conferences and change how we critique each other and think about complications. And there does need to be some kind of forgiveness at the end, both from our colleagues and like forgiveness of ourselves. So, yeah.
Yeah, this was highlighted in Kurt and Lou Marmon's article about second victim, because when there's a complication, the family gets taken care of, the institution will have a root cause analysis, but who's taking care of us in the repercussions of that? Minna?
We're pretty lucky at our Children's Surgery Center that we have a fairly robust multidisciplinary peer support group that includes representatives from anesthesia surgery, perioperative care, techs, nurses, and the PACU. And so we've developed a system where when there's an intraoperative complication or a bad death, like the past week, I was involved in a really difficult case where the child died on the table after a motor vehicle crash. And we have sort of a HIPAA compliant internal teams chat group where any one of us can post, like we post a screenshot of everybody who was involved in that case, so that different people from different specialties can make sure we're reaching out. And this includes the residents, and sometimes if it's particularly traumatic, we also notify program directors if it involves multiple residents or from multiple shifts or something like that. And that's having been both on the checking in side and the being checked in on side. The first time somebody checked in on me and it was just like a PACU nurse, she's like, I heard that there was a really bad case this morning and I know you have other things. Are you doing okay? Do you just need us to go a little slower so that nobody's blaming you for running late or anything like that? It was like, it caught me really off guard, but I felt so blessed to have somebody who wasn't even a peer. Like, I don't actually even remember her name. But just ask, like, are you okay?
Wow.
So I'm just going to jump in really quickly, if you don't mind, Mindy. Nina, thank you so much for sharing that. And just along those same lines in the chat, Patrick wrote something that we've been talking and thinking about a lot, and is actually kind of one of the things that we hope to come out of moral distress episodes like this, is that, even though it is the right thing to do to ask, we'd like to be able to try to support a community where you don't have to ask, where people can recognize that there's something going on, and then kind of offer up help or step in, so that the person doesn't have to overcome those surgeon culture forces and everything to be able to, the thought of being, I have to be strong and I can get through this because this is what I do. This is what we do as trainees. We, all the way through, you sort of shove everything aside and then keep going with your day, and then you can just deal with it later and dig it up out of the deep, dark depths. And then, but you never deal with it. So I think that, to Patrick's point, we'd love to be able to create a culture where people recognize that there's something going on, and then you offer help or just be there, or say, hey, you need to not do this next case, and just give. It's almost like giving permission, so without having to have somebody ask.
That's such an important point that you're bringing up, and that's one of the main reasons to do a connect and share, but also have an awareness of someone having a complication to mitigate that isolation, which just exacerbates the feelings of shame or failure. And that way the support is shared. Lauren?
Thanks, Mindy, and everybody. I really appreciate all the participation. And Tamara and I went to the same residency, so I know exactly what she's talking about with the tone of M&M. And I'm so glad she brought this up, because I think that is a common venue that almost every pediatric surgeon participates in to process bad outcomes. And what a great opportunity it is to transform that into something where it can be part of your healing, rather than something you dread and have cold sweats about and nightmares. Because I've been there too. And I think that's kind of the traditional shame and blame M&M. But I think a more like a new generation of M&M can be one that focuses on, what is the systems problem that led to this? Like almost every bad outcome, there is some systems issue. Even if that systems issue is that we don't have a system to rescue a surgeon who is struggling when they need help, and how can we work that into our process? So, I think we've really worked hard at my institution to change the culture of M&M. And I noticed it most recently. I had a patient who I met prenatally. She had a lot of anomalies. I took care of her up until she was 3 with many, many operations, and she died a horrible death of sepsis that we just couldn't reverse. And it was awful. And during the M&M, my partner said, it was weird because it wasn't the normal M&M conversation, but one of them said, Lauren, you must be feeling awful, but you did everything you could, and actually offered me support during the M&M. And it was just such a refreshing change to the old school, shame and blame and confession without forgiveness. I'm Jewish, so we don't do confession, but I still kind of got that metaphor. So I do think that is an opportunity, right? We all participate in M&Ms. Many of us might run them in our organization, or at least have some control over how they're run. And I run our M&Ms, and I'm always really careful if anything is ever going down a path of any sort of blame to shift systems focus. It is not the venue for questioning individual decision making. That is not where that should be happening. So I think that's an opportunity.
Lisa?
Thanks. So no, I totally echo what Lauren has to say about, reformatting the way M&Ms are done. I think M&Ms carry a really negative stigma, and I think that they really are trying, just starting to shift across various hospitals more towards quality improvement. And then when we run into significant events like what Dr. Emil encountered, I don't think that a standard whatever the format is for M&M, whatever you use, the Ottawa U1 or whatever, is going to cut it. I think that we really need to reformat it. But I love looking at systems issues and, you know, thinking about cases like this. I wonder if reflecting on the stigma of the surgical hierarchy and if that may have impacted what happened in this case and in similar cases like this. And as we know, surgical hierarchy is often the result of the hierarchy in surgical training, and that results in our younger trainees and our junior staff or faculty feeling inhibited or unable or scared to discuss feelings of shame or complications, and our more senior colleagues being left in a vaunted position, which is similarly a very isolated position. And I guess maybe that's a question for, you know, Dr. Emile, whether he feels that maybe that stigma of surgical hierarchy may have impacted how you were feeling at all in this situation, and did that prevent you from, you know, talking about how you were feeling until, you know, 3 or 5 years later?
Sharif?
Yeah, so I think Mindy or Terry mentioned it. I can't remember who, but there's the guilt and there's the shame, right? And then the shame is, you know, that's doesn't really matter where you are on the hierarchy. There's a tremendous amount of shame involved, especially I think when you are a bit more senior or you have a leadership, or because then it's really public. You know, you cannot, you know, if one of your junior staff, you know, you can help counsel and you can help kind of gather things and close loops. But when it happens to you, it's really, really public. I mean, you know, that cannot be avoided. So I think that's, you know, if there's something, I guess, positive to take from these incidents, and is that it really has lowered the bar for me to reach out to everybody in my division, even if they're not, you know, it doesn't have to be a surgical complication, but if I just know there's a difficult life event, or they're not feeling well, or they think they have COVID or whatever it might be, to just have a very low threshold to reach out and say, hey, listen, how are you feeling? You know, if somebody's ill and is at home for a couple of days, you know, all it takes is just calling and saying, hey, how are you doing? You know, are you feeling okay? Are things okay? And maybe they won't answer, and that's okay. You just leave them a message. But just this feeling like we're all in it together, no matter where we are on the hierarchy ladder, I think has really been a source of healing for me, to be honest. But I just want to mention a couple other things that were mentioned earlier. So after this incident, we actually started doing WW. I'm running the M&Ms tomorrow, and we actually have a WW. So WW is what works. So instead of just always concentrating on problems, we take a situation where things really went well, and we actually present that. And just like, you know, we feature surgeons who've made surgical errors or had bad outcomes, we feature surgeons who've actually had amazing experiences as well. And it really helps balance things. But the other thing we've done also is we've started actually inviting families to come to our grand rounds. They don't come to our M&M, but they come to our grand rounds, and they actually present on their experiences. And it's not families that have had, you know, amazing, you know, innovative procedures, ones that actually had, you know, went through complications, went through difficulties. And, you know, we have a family coming again next month to speak to us about that. And, you know, I have to say, like, the one thing I guess I counsel a lot of surgeons now who go through these types of events is, you know, your presence means a lot. It's a source of healing for yourself and for the patient. Yes, you cannot undo the mistake, but it actually ends up exacerbating our isolation when we feel like we're having a very difficult time addressing the patient or the family, and would rather maybe have somebody else continue the care. I think that actually is often more damaging. Presence has an amazing power for yourself and also for the family that has experienced this. And that's what I actually advise a lot of surgeons who go through experiences like this now. It's okay. Your presence will make a difference. It'll make a difference for you. It'll make a difference for the people you're trying to take care of.
Thank you. Rachel, and then I want to get to Kurt's comment in the chat.
Hi. So my program has been trying to address this like concept of stigma of presenting at M&M in the old school rating that you would receive when you were giving an M&M by changing the name of it. So we call it SWAP now, and it's like Surgical Quality Assessment Conference. And so you're just assessing the quality and assessing how you can do things better. So by changing the name, we're trying to change the focus of what it is. We still present in the same way and give the morbidity and the mortality or whatever, and you know what we think that whether it was a technical error, etc. But we're trying to shift the focus. And then we also do something called reverse M&M, where the attendings present a case that they think the residents performed really well in. So that it's kind of like, it's sort of like the WW where you're like kind of flipping the script, and it helps with like the residents being like, oh, okay, so it is okay for me to speak up a little bit and say, hey, I think that we should maybe do this, or I would like to take it here. And it's a little bit empowering.
Mindy, maybe I'll go over to a couple of the comments in the chat, because tomorrow mentioned that their current institution, what they do when they activate a bad outcome, not looking at who's at fault, but convene a meeting the next day to kind of talk about and debrief about what happened and talk about their feelings regarding the case. And this is with anybody on the team, and not really focusing on what, I guess, critiquing the case, but really talk about how it affected us. And then Kurt mentioned thinking about how we can change the culture. And I don't know if anyone in the audience has had any success at their institution making a big change.
So Tamara and Lauren, you guys seem to have made some real strides in your M&Ms. Maybe you don't think so, but it sounds like at least to me, like you've made some great strides. Can you tell us how you, is it just a monotonous drumbeat about this, or how did you make those changes?
I mean, I don't know if Tamara, please feel free to speak up. I think it's a lot easier. Like if I try to think about how would I change that in my residency program, that's very overwhelming. But I think it really starts with leadership. And I think often the people who are creating that shame and blame culture are the highest leaders. And when they do that, everyone thinks that's how you're supposed to be, and then they mimic that behavior. So I think when you have a leader who, instead of kind of perpetuating the shame and blame culture, is bringing up, I love that idea, like, reversing it with the attending presenting and talking about a resident and kind of shifting that whole hierarchy, or celebrating successes. But even when you are talking about the difficult outcomes, just to really have someone who's leading the M&M who draws the conversation away from, why did you do this? What were you thinking when you did that? I always do it this way. Why wouldn't you have done that? Which is a very common line of questioning that we hear, and more to like, how could the system have been designed better so this wouldn't happen again? I think it's a lot about leadership.
I wanted to just take a moment to really parse out some of the ethical tension in this case, because I think Connect and Share gives us an opportunity to address moral distress and explore systemic problems and the changes that we can do to mitigate experiences of moral distress, and really emphasizing what's broken in the system, and it's not an individual that's broken. Anybody from the Patrick?
I was just going to say one of the ethical tensions I think revolves around professionalism, and I think the tension is, part of professionalism is self-care and self-help and your own responsibility to maintain some balance and wellness. But at the same time, we all have our own professional identity. And as surgeons, as pediatric surgeons, that's really, really strong. And I think that strong sense of identity as a pediatric surgeon who works hard and does everything that they can to take care of their patients and their families, that gets in the way here, and it adds to the stigma of asking for help, of taking time off, of taking a break. So I think that's that tension. Like, you may know you need some self-care, but at the same time, your own identity sort of prevents you from asking for help or taking time off, or whatever it is that provides you some balance.
Thank you. Erica?
Yeah, Patrick, I think just to piggyback on that a little bit, I think the other thing, sort of ethically, we have this fiduciary relationship to care for our patients. And I think that sometimes balancing that obligation, that ethical expectation to provide the highest quality care can conflict with our own obligation to ourselves and our professional obligation to assure our own wellness and our own safety and our own recognition of when perhaps we are not offering the most beneficent care because we haven't cared for ourselves. So I think I see that ethical tension come into play as well.
I want to take Tamara.
Oh yeah, I was just gonna say, I do think there is an ethical tension in that we do have to at some point talk about what went wrong. I also do a lot of global health stuff, and I feel like sometimes some of the cultures that I work in, nobody will say, I dropped the cup. They say like, oh, the cup dropped, but nobody will ever say like, I dropped the cup. And I think at some point it is important when things happen that we say like, yeah, I did screw up. I did drop the cup. I did like not do something right, and own that. So I think there is a tension there. Like, how do you own it, but don't let it devastate you when you own it?
That's the distinction between guilt and shame. Guilt, you identify a behavior where it went wrong and you correct it, so the next time it doesn't happen again. And that's a really important component, I think, of the resilience after a complication. I want to turn this over to the Wellness Committee because there's a significant component. Moral distress is different than emotional distress, but I think there's a significant component of emotional distress here, and they're going to share what we can offer APSA members.
Okay. Lauren, you want me to share my screen?
Oh, sure. Thank you. Sorry, I missed our immediate prep meeting, so I don't want to monopolize this whole part of the meeting. I think, when Kurt was asking about how do you change culture, I do believe, and Minna mentioned peer support as well. I think it's a very powerful way to change culture. I think the whole concept is, when something bad happens, I think our natural reaction in many cases is just to sweep it under the rug and not want to talk to the person because we think we'll just make them feel more shame or embarrassment, when really it just increases isolation. And I think Minna kind of testified to the fact that having a robust peer support network in your institution actually really helps promote culture change. But I think many of us are not fortunate enough to be in institutions that have that up and running in an effective way. We started a peer support program here at Nemours about 2.5 years ago. And I do think it's changed culture. I think whereas in the past, if there was a bad complication, the next day people are sort of avoiding eye contact and walking the other way when they see you in the hallway. And now I've definitely noticed people saying wow, I heard what happened. How are you doing? So I think this is a powerful tool. We have, over the last couple of years within APSA, been building some resources around peer support. I think we saw with the show of hands on the beginning of this call, I think almost all of us raised our hand when we said we've kind of had a time where we had a bad outcome or a time where we needed help. We asked on the wellness survey whether you have personally committed a medical error that resulted in patient harm or death. Almost 80% of us said yes. And only 25% of us were satisfied with the support that we received after the error. So we can go to the next slide. When we asked who would you want to be contacted by after an adverse event, only about 11% of us said that we wouldn't want to be contacted by someone, and most of us said we'd want to be contacted by one of our partners. So I think this again speaks to the need for us to be having these conversations with each other and overcoming these barriers and to having these conversations. Go to the next slide. So in order to provide some sort of general background and education for pediatric surgeons and really anyone, we put together these 3 episodes that you might be familiar with. There's a QR code here that takes you to them. Each of them is introduced by a testimonial, kind of similar to what Sharif shared with us all tonight. The first one's from Ed Barksdale, and the second one's from Steve Stylianos, and the last one is from Marge Arca. And it, introduces with a testimonial and then gives some background information. First one is just like general moral distress and peer support. The second one is more specifics about how peer support can help and what's the data for it. And then the third one is really the nuts and bolts of like, how do you actually conduct a peer support encounter? So the thought is if you watch these 3 episodes, you would kind of understand the basic skill set and be prepared to do it for your colleagues. We also have created a peer support program through APSA. We've trained a bunch of APSA members to provide peer support, and we had role play. Joe Shapiro came in to do the training, who is a real kind of international thought leader in this realm. And this is a QR code that takes you to the website. And I'm just going to quickly click through how you find it if you're on the APSA website. I would really love everyone on this call to be aware. It's under resources, peer support program, and then that takes you into the portal. There's a little short video kind of describing the program and how it works. And there's Ed's testimonial on there as well. And then if you scroll down the page, it gives you also links to the episodes that I just mentioned. And then if you scroll further down, there is the portal. And there's an online intake form. You can refer yourself or you can refer a colleague or anyone that you're worried about. This is not limited to only pediatric surgeons or only APSA members. We have provided support to a surgeon in Italy. We've provided support to trainees as well as, full-fledged pediatric surgeons. And then you can actually select from a drop-down menu of the people who have done the training if you want to speak to someone specific, or if you don't, the referral just goes in and then I can help match people. Go to the next slide. This is the full list of peer supporters who have completed the training. I'm very grateful to all of you. And then the next slide is interesting to see the breakdown in terms of how long you've been in practice. We have a lot of senior surgeons who've done the training, but we have a pretty good spread of quite junior as well as, mid-career. I think that's the last slide. Yeah, if anyone has questions about it, we have I have gotten a lot more interest in people who want to become peer supporters than people who need peer support. We would love to drum up more referrals and just kind of spread word that this program exists, because I do think it's a powerful tool to support culture change.
Thank you for sharing those resources. Patrick, I'd like you to elaborate a little bit on your comment in the chat, because I think it's really important in terms of more senior people being role models to our trainees, please.
Well, yeah, I was just going to say, for those of us that work at training programs, I think first, our fellows will experience this. So while we have to look out for our colleagues, our partners, we also have to look out for our fellows. And sometimes, and we had a session on the ethics of wellness at the ACS last week, and I spoke as a program director. Sometimes it's not easy to recognize that, because as a program director or in any program, any pediatric surgeon, you're busy and doing other things. So keep an eye out for your fellows, I would say. And the second thing is, if something like this happens to you, asking for help. Another sort of ancillary benefit is, in addition to the benefits to you and the patient, it shows the fellow that none of us are immune, and I think you are acting as a role model in that instance.
Lisa?
I couldn't agree with Patrick more on that one. If our fellows and our residents don't see us asking for help, then they're going to model after us. So the more they see us as, staff asking for help and modeling good behavior, the more they're going to see that that is an okay thing to do, and that is accepted, and that's how we change culture, right?
There's been a lot of emphasis in this discussion on M&M, but in looking at systemic issues, there are multiple things going on, and that's, do we take care of the patient, the hospital, the insurer, the EMR, our healthcare system, or the productivity metrics? And these are all the external constraints and stressors that impact us and create moral distress. And I think it starts from the top down in terms of being role models, but again, highlighting that moral distress, we need to locate the source of the distress in a broken system and not a broken individual. And it's beyond M&M, and creating a culture where you can ask for help or just have a greater sensitivity of somebody needing help is important. And this is how we're going to address long-term solutions to shame and blame, and just identifying when we have a complication, it's reparable, it's a behavior that can be changed, and softening the blow with greater support, with cohesiveness within our divisions. Liana?
Hi, so I've been putting some questionnaires in the chat, and I think one of the things that we don't realize is what has been said before, like we don't realize how much we have on our plate, because it's just, just move forward, move forward, move forward. Babies die, keep going, that sort of stuff. And we don't even take a second to realize, like, there's a trauma questionnaire and you're like, wow, I can check a lot of these boxes. Just even if I am a pediatric surgeon, you can check a lot of the boxes. So we get to handle a bunch more trauma than the average person. And I think it's important to have awareness to that. And then the second thing is the depression questionnaire, just to have awareness, to see, like, where are you? Is it of a concern or not? Or is it getting worse, better? Where are you? Just to have some sort of gauge of where you are, where you're headed. Because I think a lot of it is just not recognizing how we transform through medical training and career, and how that can show up and be sneaky. So I think those were a couple of questionnaires I kind of put in that are easy to take really quick, and they're pretty eye-opening. There was one other questionnaire I put in there. It was a PTSD questionnaire, and like Emil said, things started happening that weren't always happening before his traumatic event, and then how that shows up. So I think those can be helpful, and if you have awareness, then you can get help. I mean, we see a lot of traumatic things, and so there's a whole field of therapists and psychiatrists that are there for us, but it's been so stigmatized that if you need more data to collect and say, look, you are depressed by this questionnaire, not saying that you should start treatment without somebody, but at least having awareness that, hey, you're hitting some targets that you might not be aware about.
Thank you. I think they'll be helpful in creating self-awareness. Brad?
Hey, thanks for the forum. Really love the discussion. I just want to reinforce something that Sharif touched on, and Kurt mentioned several minutes ago. A lot of these, and this happened to me, a lot of these significant adverse events happen in the middle of our call shift, after hours or at night. 5 years ago, I had a 8-year-old with undiagnosed lymphoma. 2 days before I did a liver biopsy on him, he was started on steroids for suspected bronchial pneumonia. or bronchospasm. And so he was in full tumor lysis syndrome when I put him to sleep to do a 20-minute liver biopsy on him. It was 9 o'clock at night. He was riding around on his tricycle in the preoperative area when I was talking to his family about doing a 20-minute laparoscopic liver biopsy on him. He died in the OR. And it's as I was walking out the room to talk to this family that I didn't know, I got a page. We're helicoptering a 1,500 gram infant from Duluth with free air that's going to need an emergency operation. So I think that you know, it's the concept that, okay, we're going to go through this amazing process of, you know, delineating grief and horrible news to a family, and then we're going to somehow go do a complicated operation in the middle of the night. I mean, it's just not realistic, right? But it wasn't even in my mind, well, you should call one of your partners to come in and, you know, take over for you or to help you. I mean, it wasn't even in my, and this was just 5 years ago. It's not like this is back in the, you know, 1990s. And so I think that notion, I would really give credence to the fact of advocating for, you know, within partnerships of, we need to get used to kind of covering for each other when these adverse events happen. And we can't just automatically be expected. Yeah, we're going to be on top of our game regardless of what happens. So, you know, I was thinking that when Kurt mentioned that a while ago. So I just wanted to second that.
Thank you. Kurt?
Is this?
You have a couple great comments in the chat. Thank you for sharing.
I was just curious, we've had 3 experiences tonight where somebody had a death or a tragedy and then kept operating. Is this a theme that's common in our culture, or are the 3 of us just anomalies? I was surprised that I mean, I was resonating with Sharif when he did it, and then when Brad talked about it, it just made me wonder if there's more to this than we're appreciating.
I think you raise a really important point in terms of I'm sure if we had more time, we could have another show of hands on how people view immersing themselves into work as part of their coping mechanism. And I think in addition to what Ileana brought up in terms of identifying and having self-awareness of symptoms of PTSD or trauma, I think we also need to have an awareness. I just lost my train of thought. Sorry. You said, and an awareness of how do we cope with these types of situations. And if the coping strategy is to continue working and immerse yourself in call, you're not addressing the core issue of what's bothering you. And once you have the time and space to identify the emotions and feelings that you have and reflect on it, you may have other situations or experiences of moral distress that further compound it. And even though each individual experience may seem trivial, it becomes very significant because you don't recover, and this results in moral injury and moral residue. Ileana?
Well, another thing I would say is that sometimes it can be uncomfortable to utilize your partners, right? So I think that's why it's very important to have APSA have a space. If you may not be with supportive partners, or there just might be some sort of block, even if you have the best partners, they're the most supportive, but for some reason you want to kind of compartmentalize it into some other aspect of your life. So I'm really excited that APSA has that sort of a pop-off valve for people. It's not limited to just pediatric surgeons, but I think that's a great step in the right direction. The other thing that I wanted to mention that I'm not sure because I blinked, but I may have missed that. The Connect 5 program, which is kind of just an awareness of, hey, regular check-ins with people who you care about and trust can be important to keep tabs on yourself if you may be unaware. As Kurt mentioned, we have some blind spots even to our own being, and your friends or people who know and love you can pick up sometimes what you can't see right now. So they can bring some heart to what you might be trying to wall off.
So I know we haven't all read every single one of the chats, but there's some really great comments in there that speak to this. Sorry, Eliana, I don't know if you were done, but thank you so much for sharing. And everybody actually, I think that in the chat and also on here, the stories could probably go on and on and on. And I think it's a lot of the theme that I'm seeing in the chat also is this culture of not asking for help and then declining it when it is offered. And I think that I don't know, that talking about it actually will at least start the conversation. Like, it's okay to accept help, and it's also okay to offer it. I don't know anybody who experiences a complication and then doesn't want people to talk to them about it or reach out. And I know a ton of people who, just to speak to the survey, a ton of people who, when something bad happens to a friend or a colleague, they're like, oh, I didn't talk about it with them because I just didn't know what to say. And I think that just even reaching out or taking them aside, even if you don't know what to say, it means something. And then it also opens the door to actually talking about it. So, Terry mentioned perhaps the partner should just scrub, even if you don't step away in the acute aftermath. I think that I think some of those things, even if we don't even know what we need, if we can't identify that there is a need first. But I think I would feel very comfortable if one of my partners after this just said, you know what, I'm going to scrub with you. And I might be so in a fog that you know what, fine. Yeah, that's fine. That'd be great, or whatever, but it just seems like it's a lot of culture that needs to be changed. We're a team sport. Gone are the days of the surgeon that just walks into the room and rules the roost and is like a hardened person who just is a machine. We're not superhuman. And a team sport also means dealing with some of this culture as a team as well. So I'm not going to read all the things in the chat, but I encourage you guys to read them because they're very on point. And thank you so much for sharing.
Yeah, I think just to summarize a couple good things is for everyone to remember, like as Sharif is saying here, that even if you have a complication, you're still a good surgeon. And it's sometimes really hard to remember that.
I think I'm going to defer it to Patrick and Erica, but I think that's a great note to end on for this discussion.
Agree. I think it's the perfect note to end on. So I thank everyone for your bravery and sharing and supporting each other. And I've learned a lot, and I think there were a lot of really great lessons discussed. So thank you for a great discussion. We'll look forward to continuing.